Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about Zoloft, also called Sertraline. This is an antidepressant that was first approved by the Food and Drug Administration in 1991 and went off patent in 2006. It's part of the family of the SSRI, selective serotonin reuptake inhibitors like Prozac and Paxil and Lexapro and Celexa. These drugs are very popular because it's said that they have fewer side effects than other antidepressants. They're extraordinarily popular. If we go back to 2005, well, we find that Zoloft was the most popular antidepressant in the United States market with 30 million prescriptions written. Actually, it was the 6th most frequently prescribed drug in the United States. Brought in revenues in excess of $3 billion, and by 2013, it was the 2nd most frequently prescribed psychiatric drug in the U.S. If we look at all of the people taking the medicine, it's mostly people between the ages of 18 and 44. Women outnumber men by about 2.5 to 1. But even if we look at outside that age group, we find that 3% of all women between the ages of 40 and 60 are receiving the drug. And once you get a prescription for the drug, there's about a 60% chance, 60% chance, that you'll be on the drug more than 2 years. And there's a 1 in 7 chance you're going to be on the drug for in excess of 10 years. Now, the drugs are indicated for a significant number of medical issues. They're indicated officially for major depressive disorder, post-traumatic stress disorder, PMDD, premenstrual dysphoric disorder, obsessive compulsive disorder, social anxiety disorder, and for panic. They're not for people who are less than age 18, except if they happen to have obsessive compulsive disorder, where it's okay to treat people between the ages of 6 and 17. It's not for people who have a family history or a personal history of either mania or hypomania or bipolar disorder that we used to call manic depressive disorder. It's used for a variety of off-label uses without significant documentation that is really helpful. For instance, in alcoholism or migraine headaches or diabetic neuropathy or personality disorders, hot flashes, obesity, eating disorders, premature ejaculation, Tourette syndrome, and even generalized anxiety disorder. Now, if we look at major depressive disorder, supposedly occurs in about 7% of the population at some point in time. But most of the people who have depressive symptoms don't meet the actual diagnosis of depression. You have to have a certain number of conditions in order to meet the diagnosis of depression. One of the problems is that depression tends to come and go by itself. These drugs, Zoloft among them, seem to work better in people who have more severe depression than people who have mild depression. And unfortunately, most of the people who are given the drugs are evaluated in a very few minutes by either a family doctor, a general practitioner, a nurse practitioner, a PA, and they haven't seen a psychiatrist. They haven't really gone through a formal evaluation to see if what they consider depression actually is a medical diagnosis, or is it just the popular vernacular? Well, it's important because the effect of the drug is only about 10 or 15% more effective than a placebo. And there's evidence that only about 1/3 of the people who are given an antidepressant are going to receive any benefit from the treatment. The studies showing that the drugs are good are relatively small. They're short in duration, lasting somewhere between 8 and 12 weeks. And they use criteria for the diagnosis of depression that isn't even used anymore. The diagnosis of depression keeps changing. Well, the drugs work, supposedly, because they inhibit the reuptake of serotonin. That means there's more serotonin floating around the nerve cells. And that supposedly is going to be able to treat the depression. But serotonin also is involved in the platelet functioning. The platelets are the little substances in the blood that help you clot. Well, if there's too much serotonin, that effectively alters the way they work. The selective serotonin reuptake inhibitors like Zoloft don't have any effect on dopamine or norepinephrine or the benzodiazepine receptor, the GABA receptor in the brain. You can take the drug with or without food. The standard dose is about 50 milligrams, but it comes in 25 or 50 or 100 milligram sizes. Typically, in certain conditions, it's begun at a lower dose and it can be gradually increased up to 100 milligrams. But for the most part, 50 milligrams is the dose that we're aiming for in some people. For instance, if you have post-traumatic stress disorder, social anxiety disorder, ultimately may need a dose that's significantly higher, up to 200 milligrams. And PMDD, not only does it seem to help the mood and can be given the entire month or just in the 2 weeks before the menses, not only does it help the mood, but it also helps the family interactions, the quality of life, and may even improve some of the physical symptoms that women experience, the breast swelling or tenderness. The half-life of the drug is about 24 hours. It goes through extensive metabolism, what we call first-pass metabolism in the liver. It's changed into N-desmethyl sertraline. The half-life of Zoloft is 24 hours, but the half-life of that metabolite is between 62 and 104 hours. It's less active than the Zoloft, but it means that since we have a drug that has a very long half-life, that the dose shouldn't be changed too frequently. If the dose has to be increased, you wait for about a week because it takes that long to equilibrate. The excretion, about 40% is in the urine, about 40% is in the feces as byproducts, about 10% is going to be in the feces as unchanged Zoloft. If you have liver disease, we have to begin at a smaller dose if the disease is mild. If you have moderate or severe liver disease, you probably shouldn't take this drug. It's not really an issue if you have kidney disease. Talk about taking the drug during pregnancy. Is it safe or is it not safe? There's a big argument, but it would appear, at least in the third trimester, there's an increased risk for persistent pulmonary hypertension in the newborn. So it's not a good drug for the third trimester. And neonatal complications include hospitalization for respiratory support, need for tube feeding. Baby is irritable and jittery and might be cyanotic and have a constant cry. Twofold increase in the incidence of heart defects, small increase in fetal deaths. There's a questionable link to autism if it's prescribed in the second or third trimester. Some babies have withdrawal symptoms after birth. And there's question about, in animals, is there a delay in the ossification? So overall, it's probably not a good choice for women who are pregnant. Breastfeeding, no real good information. Remember I said it interacted with the platelets, so it can cause some bleeding. It might interact with warfarin or antiplatelet drugs or even aspirin or aspirin-like drugs. So extra caution, because sometimes a person could develop significant gastrointestinal bleeding, potentially even life-threatening. Maybe just nosebleeds or hematoma or bruising of the skin. Shouldn't take it with St. John's wort or with alcohol. It changes the metabolism of some of the drug metabolizing enzymes in the body. So you have to be careful if you're taking Zoloft and then additionally take an antidepressant like dizipramine or Effexor or an antipsychotic or even the cough syrup, dextromethorphan, or one of those medicines for overactive bladder, tolterodine, or a heart drug known as metoprolol that's extraordinarily commonly prescribed. If you take Zoloft, you might even have a false positive urine screening test that suggests you're taking a benzodiazepine. It's common side effects of the drug: nausea and diarrhea, both about 20% of the time. It could cause your weight to go up or down. It could cause you to have dyspepsia and perspire and feel tired, cause sleepiness, or could cause insomnia, could cause a dry mouth or tremor, headache, or restlessness. It can interfere with your sex life. It causes erectile dysfunction, old-fashioned impotence. Or it can cause ejaculation delay or problems with orgasm. And even after you stop the drugs, can cause what's known as a post-SSRI sexual dysfunction disorder with genital anesthesia, or premature ejaculation, or nipple insensitivity in women, or issues with vaginal lubrication. In real life, the loss of sexual interest or sexual abilities occurs in a significant number of people, estimated to be as many as 1 person in 3 taking the drug. Discontinuation might be difficult for about 1 person in 12 taking the drug. Weight gain in about 16%. Dry mouth, sleep disorders, very common. There's a black box warning, especially in people less than age 24, of an increased incidence of suicide if you happen to be taking the drug. Well, you shouldn't take the drug if you're also taking either lithium, an MAO inhibitor, tryptamine, pimozide, an amphetamine, fentanyl, or selegiline, because that could cause something known as the serotonin syndrome. Even the Zoloft by itself can cause the serotonin syndrome. Serotonin syndrome is associated with nausea and vomiting and diarrhea, mental status changes associated with agitation and hallucinations and delirium and coma, loss of consciousness and seizures, associated with autonomic instability, with labile hypertension, your high blood pressure, low blood pressure, switching around, and flushing, and the body temperature going up, and a racing heart rate, and neuromuscular symptoms, tremor and rigidity and incoordination, and increased reflexes. So got to be a little bit careful of mixing drugs. And in 2015, a study from Wake Forest University on female monkeys showed that this drug increased the likelihood of coronary artery atherosclerosis, hardening of the artery. Increased it by about 3-fold, and in depressed animals, increased it by about 6-fold. And observational data shows maybe about a 50% increase in the stroke risk, and women who were taking the SSRIs seem to have an increased risk of myocardial ischemia and possibly subsequent stroke. Well, as we've said, you have to be careful if you're at risk for mania or hypomania. The drug can precipitate events, also precipitate seizures. And people, especially older individuals or people who are volume depleted in the summertime, you've been sweating a lot and haven't been keeping up with your fluids, or you're taking a diuretic, well, it can cause your sodium to fall. And if the sodium falls too low, it can cause headaches and difficulty concentrating and confusion and weakness. Can cause some unsteadiness and falls and hallucinations and syncope, fainting, and coma, and even respiratory arrest. Well, could you overdose on the drug? Sure, you could overdose. It's typically not fatal if it's the only drug, but it probably is going to cause you to be sleepy and vomit and have nausea. Your heart's going to race. You're going to be agitated, and you have tremor and dizzy, and might develop some arrhythmias, even pancreatitis. And then that serotonin syndrome may occur. Let's say you've been taking the drug, you want to taper off of the drug, you should taper off, you shouldn't slowly stop. But there's a discontinuation syndrome. It's most intense during the first week. It occurs, according to some estimates, up to 60% of the time. And when you taper off the drug, you might have symptoms that you think are reminiscent of a relapse of your depression, but it's really a withdrawal syndrome. Dizziness, loss of coordination, fatigue, tingling of your fingers or your toes, or burning, or blurred vision, or vivid dreams, or insomnia, or flu-like symptoms. Then some people become anxious or have crying spells, become extraordinarily agitated, and have sensory disturbances like electric shocks. They're confused and they have headaches. There was a 60-minute episode a while back. It did a segment on antidepressants, and it said that they weren't really significantly more effective than placebo. Actually, This is a drug, Zoloft. It's on the worstpills.org list. Supposedly just as effective as the other antidepressants. No more effective, no less effective. For the elderly, there might be increased in nausea, but it might have fewer side effects than some of the drugs like the older-fashioned tricyclic antidepressants in the elderly population. A study in February of 2018 in the medical journal called Lancet looked at 522 different studies involving antidepressants. There were more than 115,000 people who were reported on, and it was found that the antidepressants were only 15 to maybe 50% more effective than an inactive placebo. And that's with a quarter of the studies being funded by the drug companies. Now, Pfizer, the maker of the drug, was sued, and it was alleged at the time of the suit that the company was paying prominent doctors to tout Zoloft, and that the company paid doctors to be authors of papers that they didn't really even write. Well, how much does the drug cost? It doesn't cost very much now that it's off patent and made by so many generic drug companies. You can buy it for cash price, less than $20 or $30. And if you have a coupon, less than $10. Now, interestingly, in November, the end of November of 2018, there was an article, a Viewpoint article, in the Journal of the American Medical Association that we now call JAMA. It showed that antidepressants are more effective than placebo, but not all patients who receive treatment with antidepressants seem to recover. Actually, there's a high rate of spontaneous response in people receiving the drug or a placebo. Actually, it found that about 54% of the people receiving antidepressants responded, but 38% of the people not receiving an antidepressant, receiving a placebo, responded, and people who were just not doing anything seemed to show comparable rates of improvement as the people receiving therapy. And if you receive the therapy and you get better, we don't even know if it was the drug that made you get better, because remember, this is a condition that seems to come and go. It waxes and wanes. And about 30% of the people who have depression are going to have symptoms that unfortunately don't respond to any of our therapies. And if you're taking the therapy, the relapse rate while you're still taking the therapy is very high. It's about 50% at 2 years. And there's limited evidence of long-term effectiveness of this class of drugs. And interestingly, there's no good evidence that one of the antidepressants actually functions as a better antidepressant than any of the others. And as a matter of fact, some of the internet-based interventions seem to be very effective, and they don't require taking any medicine that might have a side effect, and they don't involve you're even leaving the house. So what's the bottom line? The bottom line is the SSRIs remain extraordinarily frequently prescribed and overused. And the diagnosis in common practice of depression, well, you have to be skeptical, because a lot of people say, well, geez, I'm depressed, but that's not a medical diagnosis. And that shouldn't necessarily warrant your taking a pill. But we do know that once you start taking therapy, chances are you're going to continue. And these drugs do have some significant side effects. The only good news is that now they're relatively inexpensive. If you have questions about these antidepressants, we've done a series of shows on multiple different drugs. You might find them interesting. Thanks for watching. I'm Dr. Ken Landau.